Hi everybody, welcome to part 2 of my presentation. So where we left off last time is we were talking about something as simple as protocol deviations and adverse events are now becoming quite complicated, and more complexity means more expenses to R&D. So another example, labs. Even something simple like lab analysis is becoming very convoluted. For instance, I'm working on a study right now that's using 5 different central labs as well as local labs. Also, for each study visit, it requires its own specific lab kit, which can get complicated when the wrong lab kit is used, or if lab kits expire, or if the site runs out of stock right before a visit. So again, something that seems simple to outsiders is actually quite complex and expensive. Another example of huge expense is electronic medical records. So many institutions are now requiring the use of EMRs, and while they have their benefits, they also have their downside. They have a tough learning curve. Sometimes the printed copies don't match the system. Sometimes there's discrepancies. And often what I find on site is there's an overload of information. Every time a patient has a new visit, it transports all their records into this new visit, so it's just an overload of information. And a recent study has actually found that on average, doctors waste an extra hour of every single day due to EMRs. So this, combined with the high cost of the system, significantly contributes to the R&D costs. And there's also examples of some sites have told me that they now are required to carry cyber insurance. Since records are stored electronically, they need cyber insurance, which can also add costs because it's expensive insurance. It also can hold up study contracts and the progress of studies. So, to put things in perspective, here are some staggering statistics. In 1975, the average cost of bringing a drug to market was $100 million. In 1987, the cost was $300 million. And today, it's estimated to be between $1.3 and $2.2 billion. And these numbers are actually in inflation-adjusted dollars, so they've been corrected for inflation. A study by Tufts found that the actual cost of R&D, including post-market studies, is actually closer to $2.2 billion. So even though right now we have, looking at this graph, it's showing 1.3, when you tally up all the tertiary costs, it's actually closer to 2.2 billion. And the researchers actually also found that comparing data between 1999 and 2005, the average length of clinical trials has now increased by 70%, and the average number of routine procedures per trial has increased by 65% just in those 6 years. So we've already discussed reasons for the rise in costs, so I won't read each bullet point here. But just to highlight the severity of the rising costs, Forbes recently total R&D spending from 12 leading pharmaceutical companies between 1997 and 2011, and they found that they had spent $802 billion to gain the approval for just 139 drugs. So this calculates out to a staggering $5.8 billion per drug. So here are some examples of the effects of such high R&D costs. Hep C has now been cured, but the downside is the treatment costs $1,000 per pill. AstraZeneca came out with an ovarian cancer treatment that costs $6,500 per month. There's a cystic fibrosis drug that recently made it to market that costs $400 per pill. And there's also a prostate cancer drug that's also too expensive for many people to afford. And another complexity to this issue is that countries with socialized medicine, like the UK, where the government pays for the patient's medications, the government recently rejected the use of AstraZeneca's ovarian cancer treatment because they simply cannot afford it for their citizens. So it's actually not just in the hands of the patients, it's affecting governmental decisions as well. So clearly we need to change the way things are going so that we can start producing drugs that are, once again, affordable. So we need to find solutions to these problems. So we need to promote innovative thinking, we need to streamline processes, and we need to use technology to our advantage. So we can start by creating uniform, standardized trainings that can be applied across sites, across studies, and so that we can use this technology to enhance the training experience and cut down costs, such as having investigator meetings done remotely. And we can start to use creative techniques like using avatars in virtual training rooms, or making presentations a bit more exciting. For example, maybe thinking outside the box and using a new delivery system like Prezi instead of PowerPoint. Strategic partnerships are also critical for reducing costs. These are partnerships between major pharma companies and major contract research organizations that, when you do work with the same partners frequently, it can expedite contract negotiations, it leads to transparent views and expectations, and enhances the knowledge of each other's policies. We can also utilize shared comprehensive databases to keep track of our best sites, our best patients, our best investigators, our best monitors, and this allows for the sponsors and the CROs to make the right decisions earlier on. So good planning is always critical for reducing costs. For example, a smarter protocol means fewer amendments, which leads to less retraining and lower costs. Good planning also means that we take sites' feedback into consideration when planning the trial design and recruitment strategies. So, another important element, of course, is communication. So when the planners communicate with the implementers, things start to come together to create smoother operations with fewer kinks and less costly adjustments. As we know, the majority of costs in clinical trials are happening in the phase 3 portions of clinical research studies. It's actually estimated that 90% of the total R&D costs of developing a new medication happens during the phase 3 trials. So if we can identify the failures early, it saves hundreds of millions of dollars by avoiding trials for unnecessary trials for drugs that are never going to make it to market anyway. For example, an example would be to conduct risk assessments earlier on. So, does this diet pill have a high risk of heart attack based on the data in the investigator brochure? If so, let's make it a primary endpoint in the study and pay close attention to it so that further tests aren't needed after you submit the NDA to the FDA. Good organizations and good choices always start with good leaders. So you need to have organizations like big CROs and big pharma companies, and even in the site level, that have leaders that are open to feedback, are supportive, are transparent, and that are proactive instead of reactive. Another way to reduce costs is to avoid the duplication of work. So this requires communication between internal departments as well as external vendors. And this is key in creating efficient processes and avoiding redundancies. So for example, if you have an in-house CRA, like in bullet point A, who's doing remote monitoring, they need to communicate with the CROs at the site level so that the CRA is on the site level so that they're not repeating work that's already been done remotely. Turnover costs a lot of money because it disrupts processes, it resets the learning curve, and managers and leaders really need to be proactive in retaining top talent so that these studies run smoothly and that unnecessary costs are avoided. So it's really important that clinical research sites and CROs and sponsors start to focus on retaining top talent. And again, that goes back to being proactive instead of reactive. Adaptive monitoring, aka risk-based monitoring, is a new cost-effective, smarter approach to monitoring clinical trials. So instead of focusing on 100% source stock verification, we're going to do more targeted SDVing. We're going to do remote monitoring since we have the capabilities with this technology to go into electronic portals and to review data at home before we're on site. And we can focus our efforts more on the high-risk sites and less on the low-risk sites. So if you have a site that's a high enroller, that has lots of deviations, that has lots of staff turnover, they probably need more attention and source doc verification than the site where you go out there and you never find any problems. So, just to sum up everything here, what we had past pharmaceutical blunders and recalls that led to public outrage, which led to FDA having tight regulations and strict reforms. And at the same time, we had a technological explosion where tests are now very convoluted, complex, costly, and there's an infinite number of layers of testing that can be done during these clinical studies. And so this has led to huge R&D costs. If you remember, the estimated cost of up to $5 billion for a drug to make it to market. And these high R&D costs translate to the patients so that people can no longer afford their medications. So what we really need is we really need to be innovative and creative and adaptive in solving this problem. And as you saw, there's quite a few slides in this presentation which supports the fact that there's no simple solution. It's going to be an ongoing collaborative effort, and I'm excited to see where we take this. Thanks so much for your time.